This presentation will cover nutrition for disorders of the liver, gallbladder, and pancreas. By the end of this presentation, you should be able to identify the importance that the liver, gallbladder, and pancreas plays in terms of proper digestion. You will also be able to describe disorders of the liver and think about the nutritional therapies that treat each of those disorders. You want to outline specific nutritional therapies for each stage of liver transplantation. Think about how diet and nutrition can be used to reduce symptoms of gallbladder disorders. You'll be able to explain how the pancreatitis alters digestion and absorption of dietary fats and protein, and review the potential need for patients to have enteral or parenteral nutritional support during the treatment, specifically of pancreatitis. Our overall wellness and well being requires that all body organs are functioning well, and our physical health is crucially dependent on ancillary organs such as the liver, pancreas, and gallbladder. These are ancillary digestive organs, and they do affect our overall nutritional status. Now, think about the connection of change when needed for nutritional or dietary guidelines that are more restrictive. It inhibits us to socialize with others. It can cause us to not cope well spiritually. It may impede with our religious beliefs. And then, of course, just coping with physical disorders as a result of those things. Think about the environment and how environmental health encompasses the ability or touches on our work and living conditions. Think about our surroundings. Are they free of toxic substances? Is there contamination of food, water, and air? So, in addition to just thinking physiologically how diet and nutrition play a role in our life, I want you to add another layer of complexity to what our patients with chronic illnesses may be undergoing. Now, nutritional therapy is going to be important for any patient that has an alteration of their liver, gallbladder, and their pancreas. Being that the liver is the largest organ in the body, right below the diaphragm in the right upper quadrant, it's responsible for most of the biochemical functions in the body. We're going to talk about how the liver manages bioproduction and also its role in metabolism of our carbs, our protein, our lipids, and our vitamins. It does a lot of work. And if any one function does not work correctly, then we are going to have a major imbalance in metabolism and nutritional status. And this decline over time can further impair our liver function and cause more disease. So let's look at figure 14.1 in your textbook to see the role of the liver in metabolism and nutrition. We remember that the GI tract includes glucose, fructose, galactose, fatty acids, amino acids, minerals, and vitamins. And the liver breaks down energy, maintaining a steady blood glucose level. That's baseline if everything is going well. It's also responsible for glycogen, fatty acids, amino acids, iron, copper, ascorbic acid, vitamins A, you see all the B vitamins, vitamin D, and vitamin K. These are fat soluble vitamins. And the liver stores these things. It also activates, produces, and excretes cholesterol, bile that moves eventually into the gallbladder. It excretes triglycerides, lipoproteins, you can see here also phospholipids, and the plasma proteins consisting of albumin helping for fluid balance, globulin, fibrinogen, and clotting factors, specifically factors 7, 9, and 10. It also helps to excrete heparin. The liver is responsible for the formation of urea from the breakdown of ammonia when it's transferred to the kidneys. It also filters blood from toxins when it's transferred from the kidneys. You can see here the importance of the liver and its connection to the other ancillary digestive organ, the gallbladder. The first disease process we're going to talk about is hepatitis. And hepatitis is when it's an itis, so it's inflammation of the liver. And acute hepatitis occurs when there is perhaps an infectious etiology. There's cirrhosis, toxic chemicals can cause hepatitis, or viral infections. There's 5 different types of hepatitis you could see here: A, B, C, D, and E, and they present with similar and distinct signs and symptoms. But overall, their immunologic and epidemiologic characteristics are very different. Let's look at table 14.1 in your textbook. It does break down the different types of symptoms, and you can compare it to the 5 different categories of hepatitis. Now, Hep A, typically transmitted from the fecal oral route, has to do with the contamination of food or water, but occasionally could also be spread by infected blood as well, or a blood transfusion, but more commonly food and water. Usually, a patient with Hep A is contracting it due to poor hand washing or stool precautions, and areas with poor sanitation have a higher risk and rate of hepatitis A. Generally, Hep B has to do with the transmission of blood, semen, vaginal mucus, saliva, and tears. IV drug users have a higher risk of contracting Hep B, patients with hemophilia, anyone undergoing renal dialysis, or if they've had an organ transplantation, they're all at risk for Hep B. If you acquire chronic Hep B, and this is determined by biopsy of the liver, you can still be healthy. There are asymptomatic carriers, but they are infectious to others through parenteral or sexual transmission. Hep B is a major risk factor predisposing to hepatocellular carcinoma, and this is cancer of the liver. Actually, in our profession, we are at risk for transmission if we are not following protocols and precautions. We should be vaccinated against Hep B, which we are. It's part of the requirements for health workers. Now, Hep C, increasing worldwide, and a major form of hepatitis in the US. This is transmitted through saliva and semen. Hep C is predominantly associated with blood exposure, transfusions, drug use, acupuncture, tattooing, and sharing things like razors. Hep C can also develop into a chronic liver disease and puts the patient at risk for liver cancer as well. And then finally, Hep E. Well, we don't talk about this as much, but Hep E is the other one with oral fecal route transmission. It is a self-limiting infection. It's generally attributed to travel in tropical climates with inadequate sanitation and patients with poor personal hygiene. I do want to just point out that Hep A and Hep E, the hepatitis with the vowels, those are transmitted through fecal oral transmission. So just to help you to remember. Okay. In the previous slide, I gave you a general overview of which hepatitis is which, and now you can see a little bit more detail on these subsequent slides. I want to point out that with Hep A, your recommendation is generally to provide supportive bed rest. There is no antiviral therapy for Hep A. When a patient requires hospitalization and IV fluids, it's typically for dehydration that's caused by the nausea and vomiting symptoms that the patient may have. In terms of our recommendations for dietary changes and alterations, we are looking to promote a balanced diet that excludes alcohol because of the insult that alcohol has on the liver. With Hep B, our adequate diet and no alcohol is also recommended. With Hep C, there's no real dietary recommendations specifically, but adopting a balanced diet without alcohol is pretty important as well. Usually, with these patients, though, to help with their hepatitis C to treat it, there is a combination therapy of interferon alpha and a drug called ribavirin. So, this is something that cannot just resolve over time without pharmacologic intervention. With hepatitis D, again, there is no dietary recommendations here, though patients that are co-infected with B and D, they are going to have the same type of recommendations as hepatitis B. So it does happen where there is a predisposition to co-infection here. Diet doesn't have to be restricted necessarily, but it does help to have a balanced diet and to remove alcohol from your dietary regimen. And so we talked about the Hep A through E, but now we're going to talk about general nutritional therapy, um, especially just working on the symptoms and looking closely at symptoms. I did mention earlier that nausea and vomiting occur quite frequently, and so hydration is important with IV fluid replacement. This is usually pretty necessary, and patients may need to take a rest from oral feeding, but as soon as possible, we need to reintroduce these oral feedings because they are going to provide energy and proteins that are needed. And we can start introducing them with small, frequent feedings, and we're trying to minimize the loss of muscle mass over time. Your book explains that this term adequate protein for this patient population is between 1 to 1.2 grams for every kilogram of body weight. This is what's most recommended for most patients with viral hepatitis here. And our dietary fats should be limited if they're not being tolerated. So many times patients with hepatitis can digest fats without problem, but if you notice that it becomes an issue, then we would limit or reduce. Now, fluid intake has to be able to accommodate the high protein intake unless there is some type of contraindication. Think about if a patient also has heart failure and they're in a state of fluid overload, then we might need to restrict fluid in that sense. But most often we need fluid to help break down the high protein diet. Otherwise, our patient is also going to deal with constipation. We're providing supplementation with multivitamins, with the vitamin B complexes. Specifically, we're looking for the replacement of B12 and thiamine. there is a decreased absorption and hepatic uptake of these vitamins, as you recall from the slide with the anatomy of the liver there. We're also providing some replacement of vitamin K to help normalize the bleeding tendency. And this is why many times patients with liver problems will present with bruising. Think about Colin's sign and Turner's sign on the abdomen wall. We're replacing vitamin C, zinc, for poor appetite. This is also recommended. And then, of course, I keep repeating myself here, but restraining from alcohol is important for these patients. Next, we're going to talk about non-alcoholic fatty liver disease. And during this process, we're thinking about the liver building up with extra fat. And this extra fat is not caused by alcohol, which can also happen. So it is often called non-alcoholic fatty liver disease, or we have the spectrum of the same disorders, and we would call it non-alcoholic steatohepatitis. And so you might see it referred to as NASH. So we're going to see that in just a second, how it progresses to NASH. Anyways, with non-alcoholic fatty liver disease, remembering that this is the most common form of liver disease in the US, the prevalence goes up to as high as 45%. And not only the US, but Western societies specifically. This has to do with obesity, patients within, well, here in the US, we have a high rate of diabetes, patients with high cholesterol, high triglycerides, and just overall poor eating habits and low activity levels. Hepatic fibrosis occurs on patients with non-alcoholic fatty liver disease in about 25% of cases, which will then lead further to cirrhosis. And cirrhosis then can lead to end-stage liver disease and progress to liver cancer. There is no effective drug therapy for non-alcoholic fatty liver disease, so lifestyle intervention is the first line of treatment, and most of this has to do with dietary changes. The exclusion of high sugar foods is really important. And then, of course, weight loss management will help, but you do not want to lose weight rapidly either, because this may exacerbate the disease process. And the most severe form of non-alcoholic fatty liver disease is NASH. And when a patient has NASH, you are now thinking about all the outward signs and symptoms that are occurring. In this stage, we will have patients complain of fatigue and weakness. You'll see more anorexia. They're just not interested in food, weight loss. You'll start to see the spider-like blood vessels on the skin. They may become jaundice. They will suffer from pruritus or excessive itchiness, edema, and even mental confusion can happen in this stage. In the stage of cirrhosis, liver cells are being replaced with fibrous connective tissues, and as well as the fat infiltration. And so when you actually look at a liver, it looks very fatty. And of course, we just talked about non-alcoholic fatty liver, but now there's a progression of these fibrous connective tissues that have been replacing the normal cells. And the damage can occur for a variety of reasons. Maybe it's hepatitis that they had prior. I alluded to this before. They can also have a type of cirrhosis that derives from the biliary area. So it's biliary cirrhosis. Chronic autoimmune diseases may cause cirrhosis. Metabolic disorders. We have chronic hepatotoxic drug use, and then, of course, alcoholic cirrhosis. So many times with our alcoholic patients, we are doing a lot of education trying to teach them about the progression of cirrhosis. These connective tissues and fat infiltrations can lead to liver scarring, therefore causing congestion of the circulation within the liver. So you have a backing of blood into that portal vein. When this happens, we have a progressive liver function decline, and this is going to cause portal hypertension. That blood is backing up, causing extra pressure. So the blood vessels in this hepatic portal area are going to enlarge, they may bulge, they are actually at risk for rupture. They back up to the esophagus, and then esophageal varices can occur. And this is when the vasculature of the esophagus become very large and at risk for rupture. So there's a lot of collateral damage to the patient's body because the liver is cirrhosed. Bleeding of the esophagus can then lead, and just the esophageal varices can also lead to esophageal cancers as well. And you can see that there is a comparison here between a normal liver tissue and a cirrhosed liver tissue. Another complication that occurs is ascites, and perhaps you remember from health assessment assessing for patients that have abdominal distension. And of course, ascites is fluid that's been trapped in the abdominal cavity, specifically in the peritoneal area. This trapped fluid becomes an issue, and the patient will look very swollen. You might have a distended abdomen. Many times you also see patients with jaundice as well. And as the liver disease continues to progress, the blood becomes shunted from the portal circulation and moves into the systemic circulation. This will cause blood to bypass the liver, and perhaps it can even lead, in very severe cases, to comas that derive from the liver. Hepatic encephalopathy. This is when encephalopathy in general, this is when we have cerebral intoxication. And this is caused by the intestinal contents that have not been metabolized by the liver. And now it's circulating through and it does reach our blood. Think about ammonia. It can't be eliminated, and this increase of ammonia will lead to hepatic encephalopathy. What you're looking for are changes in consciousness and behavior of your patients. They may become more confused. You're talking to them. They may have memory loss. There are changes in personality. And in extreme cases, you might even see some psychiatric type symptoms. You may note some other neurologic changes like muscle spasticity or spasms. You might see flapping of especially their hands and their wrist area. This is called asterixis. We have rigidity of the limbs when they're trying to flex or withdraw the lower limbs, and so they may look contracted as well. Unfortunately, nutrition cannot be the only form of treatment for these patients. We will use lactulose, which is a non absorbable disaccharide, to help metabolize this intestinal bacteria, and it will result in a lower pH stool. And this lower pH stool will trap the ammonia in the colon area, and then we can help excrete ammonia that way. So when the liver is not able, again, to metabolize the ammonia, we can give lactulose to help do this. And this is through stooling. So the way we know it's working is we will evaluate to see if it is making the patient stool, because it does have a laxative action. Remember, it's lactulose, and diarrhea becomes a common side effect. But overall, we're looking for the reduction of neurologic and psychologic changes in our patient. This diagram here just circles back to the connection regarding the portal vein area. causing portal hypertension that can lead to varices and the esophagus. The most important aspect of nutritional therapy for patients with cirrhosis is replenishing protein. They are at risk for protein energy malnutrition, very common for patients, especially if they have end stage liver disease with cirrhosis. And the minimum is zero point 0.8 grams of protein per kilogram of body weight. This is essential. But to promote positive nitrogen balance and help to avert the breakdown and increase protein stores, we may even go up to 1.2 grams of protein and even 1.5 grams of protein for every kilogram. We don't want to restrict protein for patients with liver disease because this could worsen their already really severe protein energy malnutrition. But if a if a patient is protein sensitive, and there's increased encephalopathy, branched chain amino acid based formulas can be used with restricted aromatic amino acids. And this can ensure that there's a sustained level of protein intake. We can also, we think of proteins and we connect them to meat immediately, but there are plant proteins from legumes and vegetables that can help with the patient too, because they are going to produce less ammonia. So there is a balance if you've already are working with a patient with encephalopathy. There needs to be a balance of protein. What about thinking about the overall kilocalories needed to prevent protein catabolism with a patient with cirrhosis? That's 25 to 35 kilocalories per kilogram per day. Moving on, we are looking at a sodium restriction to about 2,000 milligrams if your patient is presenting with edema or ascites. And in some severe cases, you may need to restrict the level of sodium to 1,000 milligrams a day. In terms of fluid, in relation to the intake and output, you might need to restrict your patients to 1,500 milliliters a day, and some cases even as low as 1,000. We're also thinking about patients that are using diuretics to help diurese some of these fluids. When you do this, it also depletes potassium, or it spares potassium depending on what type of diuretic you're using. So you are assessing potassium levels very astutely in terms of managing the fluid. Looking at the replacement now of vitamins, we are looking to especially replace the water soluble vitamins. Remember, those are ADEK or ADIC vitamins. You're also emphasizing the replacement of folate, B12, and thiamine. And especially if there is steatorrhea involved, then you are going to provide fat soluble vitamins in a water soluble form to help with the absorption. We did discuss fluid retention on this slide, and I do want to just tell you that there's a teaching tool in the textbook called Suggestions for Coping with Fluid Restriction. I'd like you to look at it. There's about 15 points that you can look through to help patients when they are on a restrictive fluid diet. When a patient is in end-stage liver disease, an appropriate treatment may be liver transplantation. And when this occurs, the nutritional therapy is important not only after the transplantation itself, but even before. The goals for a patient waiting for a liver transplant really depend on their weight, their status overall, and their history. But most patients in this end stage liver disease condition show that they are in a compromised nutritional state and they need special nutritional attention. It's really difficult to assess the status of a patient with liver disorders because there's so many parameters. Not only are we looking at body weight, but we're looking at the balance of nitrogen. We're also looking at their lymphocyte count and their serum protein levels. These are all affected by the other signs and symptoms and clinical manifestations like edema, ascites, if there's any necrosis of the liver cells. And so we're looking at this in a very subjective way because we can't use a blanket nutritional plan. We, however, can use guidelines to help us with this. Now, overall, we are trying to help maintain appropriate fluid shifts. We're trying to help decrease any muscle wasting, and we are trying to just overall decrease the risk of malnutrition. In each phase of transplantation, this is going to dictate what the nutritional requirements are. And I'd like you to go ahead and refer to table 14.2 in your textbook as well. It does go over the primary objective during pre-transplantation versus after liver transplantation. After liver transplantation, you want to reduce the risk of osteoporosis. You want to essentially look at diabetes, hyperlipidemia, excessive weight gain. These are things that can be addressed in addition to the energy, protein, carb, fat, vitamin, mineral, and electrolyte needs, as well as fluid. Really important that adequate calories and proteins are being offered to the patient. And this is because there is a lot of stress from the transplantation surgery. They're getting high doses of glucocorticosteroids as well. Many times early on, enteral nutrition is recommended. However, parenteral nutrition may be necessary, especially if not all the nutritional um, recommendations can be met from an oral diet or from tube feeding. So we may need to provide some parenteral therapy. And so I want you to think about, what are the risks of parenteral therapy and parenteral nutrition? When oral intake is initiated, early satiety, so remember feeling full, and altered taste can prevent adequate intake as well. Think about when you're sick, you just don't feel like you want to eat, especially after surgery. And in such cases, then we're trying to figure out, between big meals, how can we supplement some of the missing calories and some of the missing protein from the goal. Fluid loss also happens from the drains, from the surgical site, NG tubes, stool output, as well as urine. So you're measuring all of those intake and output to help determine what the post-op fluid needs are going to be. And this is not just with liver transplantation, but just generally, this is how you would approach a surgical patient. Over the long term, though, a healthy, well balanced diet is a nutritional goal because of post transplantation complications like excessive weight gain, hypertension, hyperlipidemia, and diabetes. This is why, in addition to just nutrition in general, you're thinking about what are the diet and nutritional recommendations for these processes. So you might need to make adjustments over time for calories, fat, carbs. This may also be necessary. There is a teaching tool in your textbook that reviews suggestions for coping with transplantation. Think about all the anxiety that can occur in the mental health of your patient, even depression, and think about the connection to food, overeating perhaps, or just poor eating habits when you are in a state of unwellness. There are support groups and therapies that can be added on to the patient's overall treatment plan to improve the quality of life. And nutritional follow up counseling is really important, especially if the patient has resultant diabetes or obesity. The body's biliary system is comprised of the gallbladder, hepatic, cystic, and common bile ducts. And bile is transported from the liver, the largest organ in the body, to the gallbladder via the common hepatic duct system. And you can see that here in the schematic. It's concentrated and stored here until it's released into the duodenum to help with digestion. Bile is used to expedite the absorption of fat, fat-soluble vitamins, and other minerals, which will then activate the release of pancreatic enzymes necessary to further break down food. One of the main constituents of bile is cholesterol, and this is a major constituent of gallstones. So, constituent meaning that there are high levels of cholesterol in these gallstones. When a patient has gallstones, this is called cholelithiasis. And this affects about 15% of the population in the US, especially women. They're at a higher rate if they're overweight, if they're older, or they've had many children. Gallstones are found in women who are multiparous or that have been pregnant and had many children. They are also found with patients that are undergoing estrogen therapy. If they're using oral contraceptives, it does increase their risk, as well as having a sedentary lifestyle, being obese, if you're older, and if you have diabetes mellitus. You can see in box 14.3 in your book the specific risk factors for gallbladder disease. In terms of gallbladder disease, the first thing we'll talk about is gallstones and what the symptoms of cholelithiasis may be. Many times it's asymptomatic or silent, and when this is happening, there's no specific therapy necessary because the patient isn't experiencing any symptoms. But those that are experiencing symptoms, their gallbladder may become inflamed. When the gallbladder is inflamed, this is called cholecystitis or acute cholecystitis. So different than cholelithiasis. Lithiasis means that there's actual stones. What are the symptoms and when do they occur? The symptoms are going to usually manifest after high fatty food meals, and patients will complain of aching pain, epigastrium pain in the mid epigastric area. They may be dull and increase in intensity. Think about where the gallbladder lies, just directly beneath the right lobe of the liver. So you might have some radiating pain to the right upper quadrant as well, and this even all the way up to your shoulder area in the right subscapular region. So radiation of pain. Nausea, vomiting, tachycardia, and diaphoresis may also be present. And with cholecystitis, because of this fat intolerance, and the heartburn, the nausea as well, we do need to think about too how this inflammation can present now to the liver because it's very connected. Our patient may have jaundice as well and steatorrhea. These things can also be present. The main objective of our nutritional care is to provide comfort. We're trying to decrease the patient's pain itself. And so they need to be aware of the type of foods that had caused their discomfort in the first place. Keeping a good food log or food diary is important. And again, it's usually the fatty foods that trigger. And so they're going to have to learn how to omit these foods from their diet. Avoiding fat is advised, but there is no strong evidence that supports this recommendation. But watching patients intake particular foods and those are triggering are going to be more helpful than just saying eliminate all fats. So it's better for us to recommend certain specific things that are triggering them. We want an increased intake of fatty fish, such as salmon, mackerel, tuna. Those omega-3s that are found in these fishes can influence bile compensation, which will then decrease the biliary cholesterol saturation. Remember that omega-3s are often and very commonly prescribed, even though over the counter, to patients with high cholesterol because we're trying to decrease that cholesterol. So again, decreasing biliary cholesterol helps. So we're trying to recommend high fatty foods like fatty fish. So we can't just make a blanket statement and say, don't eat anything fat. What's your implication to nursing? Well, after the removal of gallstones or removal of the gallbladder, bile enters the small intestines continually rather than in response to food. There's nothing to help regulate it. So, immediately after a cholecystectomy, patients may be given liquids until they can tolerate that regular diet. So you want to think about the progression to a regular diet. There is a teaching tool in your textbook that talks about coping with gallbladder disorders as well. Additionally, your textbook does have a personal perspective talking about a 25-year-old that is suffering from gallbladder disease. I think it's important. It is a true story of a patient. It's a little excerpt there, and I think it gives you a good understanding of how it may affect a patient even as young as 25. Okay, we are at the home stretch here. We're going to end this presentation with pancreatitis, which is an inflammatory process with decreased production of the digestive enzymes and bicarbonate necessary from our pancreas. It causes malabsorption then of fats and proteins. This acute inflammation will cause local blood vessels to become permeable, leaking fluid and leaking plasma proteins into the spaces between the cells. Therefore, your body can become very edematous and damaging. Acute pancreatitis is caused usually by excessive alcohol consumption or if there's a connection with gallbladder disease. So many times people with cholecystitis will also have pancreatitis as well. Chronic pancreatitis, however, is often associated with chronic alcohol consumption, smoking, or has a genetic predisposition. Patients with chronic pancreatitis have chronic pain, and they will have a insufficiency in both exocrine and endocrine function. Going back to acute pancreatitis really quick, this is commonly caused by excessive alcohol consumption or gallbladder disease, as I mentioned earlier. And so when I'm talking about excessive alcohol consumption, that could just be like one night or over a week. And it's not chronic. They may not be drinking all the time, but when they do, or in that moment, it did cause an acute flare up of their pancreas. And pancreatic enzymes are ordinarily secreted into the intestinal lumen, and this is where they become activated. But when the pancreas is damaged, then the enzymes are retained and then they're activated within the pancreas itself. And this is not what should happen. When these enzymes are being activated within the pancreas, a form of autodigestion occurs, and this is what's causing that severe pain. Remember, it's supposed to be secreted somewhere else in the intestinal lumen. When these enzymes, amylase and lipase, can't be secreted into the intestines, they're going to accumulate in the bloodstream then. And highly elevated serum amylase values, therefore, are a good lab indication of pancreatitis. So that is an important takeaway. It's the serum amylase that can help you to determine if a patient has pancreatitis. Diabetes can also occur as a result of chronic pancreatitis because remember, if beta cells are damaged, they're going to reduce the amount of insulin production. Autoimmune pancreatitis, this is a different process, and this is the process where immunoglobulin systemic disease occurs and in response to therapies with corticosteroids. So it may happen after the delivery of corticosteroids. The primary goal for any patient with acute pancreatitis is to provide nutrition while minimizing the secretions of the pancreatic enzymes. We're going to assess and reassess our patients, making sure that they are not in a state of malnourishment. Again, we're looking at protein and fat malabsorption, and nutritional support is needed, can be individualized in your patient, in your textbook. It says that the first 24 hours of admission after an acute pancreatitis requires a rapid response. There is evidence-based guidelines that are used to help manage patients when they're in severe pain or if they're experiencing nausea and vomiting. So the therapy that we're looking for is early enteral feeding within 24 to 48 hours being very important. And we're using standard formulas that we've used in other places to help manage gastric and jejunal tube placements. So if you want a little bit more information there, I would tell you to go look in your textbook. There are enteral formulas and parenteral nutrition that is not advised for patients with pancreatitis, and the teaching tool in your textbook goes in a little bit more detail. When enteral feeding is appropriate, then you're going to use a low-fat elemental formula, which is recommended. We do know that there's clinical evidence out there that says when parenteral nutrition is administered within 24 hours of admission, it actually worsens and increases inflammation. If you are going to feeding directly into the lower small bowel is important. And this is where the jejunum is distal to the ligament of Treitz. This area is critical because it bypasses the location associated with the stimulation of pancreatic enzymes. Low-fat enteral formulas are going to be used if this route is taken. Patients receiving enteral feedings need to be closely monitored. You're looking at pancreatic enzymes, you're checking for pain and reassessing for discomfort. If this does result in symptoms, then enteral feedings need to be stopped as well. Patients with chronic pancreatitis, those that have diabetes or exocrine insufficiencies, dietary changes are needed as well. In general, parenteral nutrition is avoided, and the use of pancreatic enzymes and antioxidants like combo of vitamins, selenium, and methionine can be used, and this helps to control the symptoms in about half this population. The last result would be surgery. Overall, the nutritional recommendations is to have less than 50 grams of fat per day, using MCT oils to help mitigate this, protein at a rate of 1.5 grams per protein per day, and the remainder of this diet is going to be consistent of carbohydrates. You're aiming for more like 6 smaller meals than 3 larger meals. We may need to replace enzymes to control malabsorption, and again, alcohol abstinence is essential. Generally, eating a high protein, nutrient dense diet, including fruits, vegetables, whole grains, low fat dairy, and other lean protein sources, will help to meet these nutritional goals. In your book, The Teaching Tool Suggestions for Coping with Pancreatitis, it does talk about, again, in a little bit more depth, MCTs, and these MCT oils are going to help increase calories that you need without consuming the density of fat.